Hello everyone and welcome back to the Physics Wala Method. I'm Dr. Patil and in this series we will be talking about essential topics from Harrison's Internal Medicine. And this session was lined up yesterday, but because of my issues with my health, I had to reschedule it today. So I begin with an apology for all those who were waiting yesterday at 4 o'clock for this session. Nonetheless, better late than never, so we are going to do this session today. Okay. Now, pyrexia of unknown origin or fever of unknown origin is one common scenario that as a practicing physician I frequently encounter. And trust me guys, I have done this clinic called as PO clinic or pyrexia of unknown origin clinic for several years, and for a physician that is the most satisfying experience when a case of fever which is being a headache to many others, that there is a struggle to diagnose, when you finally put a closure by making an appropriate diagnosis. That's a very satisfying experience for any physician. Now the topic is an important topic for an undergraduate student for sure, because this can be a 10-mark question and there are few MCQ points from this topic which repeatedly appear as MCQs. One thing before we begin we have to understand is that you have to follow the latest guidelines and the latest edition of Harrison for this topic, because the definitions have changed over time. Some of your old examiners might still continue to rely on the previous definitions. Don't bother about it. For your written exam and MCQ exam, the current definitions and current guidelines are more than enough. Okay. Now before we get into the topic, let me give you 3 scenarios and try to understand what diagnosis you think of in those scenarios. Okay. So here is a scenario number 1. We are dealing with a 30-year-old. Just give me a second guys. I think there is some technical issue. Okay, so we are dealing with a 30-year-old who presented with sore throat, fever and myalgia. What do you think could be the possible diagnosis in this scenario? A 30-year-old, sore throat, fever and myalgia, means muscle pain, sore throat and fever. I think most of us, even a quack, will diagnose this case as what? Probably a upper respiratory tract infection, or in simple words, a throat infection. Most commonly caused by viruses followed by bacteria. You go with these complaints to any doctor nearby, right? Even a quack, he will give you an antibiotic, an anti-inflammatory, or maybe an antipyretic, and he will ask you to gargle your throat with salt or betadine, and then the story is over. Okay. Now what about the second scenario? We have a 26-year-old female who presented with fever and burning micturition. What do you think should be the diagnosis in that case? 26-year-old female presented with burning micturition. Right, I think we probably know that females are particularly prone to develop urinary tract infections, and the most common presenting complaint of patients with urinary tract infection is burning micturition and fever. So we make a clinical diagnosis of urinary tract infection, right? And we have a third scenario here, a 60-year-old with fever, myalgia, arthralgia and feeling of a cord-like structure over the temple bones or temporal region with raised ESR. So when we hear this story, what diagnosis come to your mind? If you're completed second year, you're into third or final year, you should be directly able to answer this. Please look at the ESR, feeling a cord-like structure over the temporal region. I will give you a clue. This is again, age of the patient is an important clue here. A rheumatological disorder, particularly very common in elderly, with high ESR, fever, visual disturbances and a cord-like structure on the temporal region. Let me give you one more clue. It is a vasculitic disorders. It's a vasculitic disorder. Right, all of you are right. Temporal arteritis, or also called as giant cell arteritis, right? So in this case you would think of temporal arteritis. So all these 3 patients presented with fever, right? Now, how could we reach the diagnosis so easily? See, in the first scenario, if I ask you to do investigations, what investigations you will do? Probably you will do a complete blood count, a throat swab culture, or if the patient is coughing, the sputum culture. That will give you a final complete diagnosis. You don't need to do anything more. Most cases, because we know statistically are caused by viruses, we just give them symptomatic treatment, right? In the second scenario, if I ask you to do investigations, what will you do? Maybe you will do a complete blood count, a urine routine and urine culture, right? The diagnosis will be done there itself. In the third scenario, what investigations you will do? You can do the temporal artery biopsy. You can do the ultrasound of the temporal artery. So the binding thing here is when a patient presents with fever, when we take a good history, we will get diagnostic clues. So with the diagnostic clues, we will be able to narrow down our differential diagnosis, and we will have guided investigations, only required investigations. We don't need to beat around the bush and do all the investigations. But when patients present with this classical picture, diagnosis of fever is very easy. But sometimes patients present with fever, but you don't have any other potential diagnostic clues. This elderly may just present with fever and he may not report a temporal cord-like structure over the temporal region. His ESR may not be grossly elevated. In that case, diagnosing this patient as temporal arteritis becomes difficult, right? Similarly, this patient, 26-year-old female, may only present with fever and she may not have burning micturition, and she may not have grossly elevated pus cells in the urine despite having urinary tract infection. In that case, diagnosis of this case becomes very difficult, right? Similarly, a patient with, let me say, pneumonia may not develop cough, right? So in such cases, because we don't have potential diagnostic clues, the diagnosis of fever, the cause for fever becomes difficult. So when we reach a situation where patient has fever, but we don't know a potential diagnosis, right? What is the likely cause for fever? Then conceptually we call it as fever of unknown origin. Fever of unknown origin. First and the most important point you have to remember is, you will, as a physician, you will encounter plenty of cases whom you can label as fever of unknown origin. But experience and the literature and data tells us that majority of the cases of fever of unknown origin are not because of rare diseases. They are because of rare or atypical presentation of typical common disorders. In India, plenty of cases of PO are because of tuberculosis. Tuberculosis is so common. But when patient with tuberculosis presents with cough, with sputum, you do the sputum microscopy or other investigations, you reach the diagnosis. But sometimes tuberculosis can present without sputum, without any localizing signs, right? That is where we encounter PO. Okay, now let us get into the Harrison and try to understand what Harrison says about pyrexia of unknown origin. He begins first by giving the original old definition of pyrexia of unknown origin, which was given by Petersdorf and Beeson. What they said is, a patient with fever ranging more than 101 degree Fahrenheit at least on 2 separate occasions, and the duration of the illness being more than 3 weeks. Such a patient, like duration of illness is more than 3 weeks, we have documented fever of more than 101 degree Fahrenheit at least twice or more than that. And for such a patient, when we do inpatient evaluation, admit them for 1 week and do all the required investigations. Despite that, you have no clue about the diagnosis, then we used to call it as pyrexia of unknown origin. But this is the old definition. The current definition is this, which is defined as fever of more than 101 degree Fahrenheit on at least 2 occasions. The duration of the illness should be more than or equal to 3 weeks. There should be no known immunocompromised state. This is very, very important point. There should be no known immunocompromised state. Means we are not referring to an HIV positive patient here, because HIV positive patients can develop fever so commonly because of infections which become very difficult to diagnose because the inflammation is masked within them, right? And then the fourth parameter is important. The diagnosis: fever more than 101 degree Fahrenheit on at least 2 occasions, duration of the illness 3 weeks or greater, patient is not immunocompromised. Such a patient, we have done a thorough obligatory investigation and a good history taking and physical examination. We have taken history trying to find potential clues for diagnosis. We have done a physical examination trying to find potential clues for diagnosis, and then we have done obligatory. What is the meaning of obligatory? Means compulsory. We have done the minimum compulsory investigations. So despite a good physical examination, good history taking and compulsory investigations, we are left with no clue for diagnosis. Then we call it as pyrexia of unknown origin. That is the current definition. So let us put that in our note. PO is defined as fever of more than or equal to 101 degree Fahrenheit on at least 2 occasions. The duration of illness being more than or equal to 3 weeks. Patient should not be in immunocompromised state, and we have done a thorough history taking, physical examination and obligatory investigations. Now what comes under these obligatory investigations? A complete blood count, because hematological malignancies are indeed one of the common causes where patients can present with pyrexia of unknown origin. ESR, just we were talking about a case scenario of temporal arteritis or giant cell arteritis. If we had not done the ESR, we would have missed that diagnosis, right? ESR, CRP, RFT, renal function test, which includes electrolytes as well as blood urea and creatinine, lactate dehydrogenase, liver function test including AST, ALT, alkaline phosphatase, albumin levels, creatine phosphokinase. Can anybody tell me why am I talking about creatine phosphokinase in a patient with fever? Why is it important? Why is it become part of obligatory investigation? Then we have ferritin. I think second year students know that ferritin is an inflammatory marker also, apart from an indice of iron store. Then we are doing ANA as one of the compulsory investigation. So I want someone of you to tell me why ANA is a compulsory investigation. Rheumatoid factor for rheumatoid arthritis. Then protein electrophoresis. Why are we doing protein electrophoresis as an obligatory investigation? Urine analysis makes sense, right? Why are we doing CPK? Because you might have come across certain inflammatory muscle disorders, especially like dermatomyositis, polymyositis, where patients might have only muscle pain and fever and no other diagnostic clues. Later, yes, dermatomyositis, they might have those classical Gottron's papules and other rashes, but in the absence of that, CPK can give a potential clue because it is an enzyme expressed in the muscle. So elevated CPK means you have inflammation of the muscle. Why are we doing ANA? SLE can also present with fever. In fact, if you go back to the SLE topic in your pathology books, you will notice that in the classification criteria, there is a section called as constitutional symptoms, and fever is the constitutional symptom which is reported there. And while scoring to come to the conclusion of the diagnosis, fever is given 2 points. If patient has got fever, we give 2 points. Okay. Then why are we doing protein electrophoresis? Because even multiple myeloma can present with fever. Multiple myeloma can present with fever. That is why protein electrophoresis is included. Looking for that M band. Urine analysis makes sense. Urine infections. Blood cultures. This is an MCQ. How many cultures should be done before you say that okay, we have done all the necessary investigation for evaluation of fever? The number is 3. At least 3 samples of blood culture should be taken. Urine culture should be done. Chest X-ray should be done. Abdominal ultrasound should be done. And because tuberculosis is also one common infection that can present with fever, and very often it is a leading cause for pyrexia of unknown origin in country like India, tuberculin skin test or IGRA should be done. Given a choice in India, we do not consider tuberculin skin test as an important investigation for part of the workup for the pyrexia of unknown origin, because either we are exposed to tuberculosis during our childhood or we have received BCG vaccination, and in such cases this BAN2 test or tuberculin skin test might come falsely positive, right? So that is why there's a test called interferon gamma release assay or quantiferon gold. That test is preferred in India. These are the compulsory investigations. So a patient who has duration of illness 3 weeks, at least 2 occasions his fever was more than 101 degree Fahrenheit, not immunocompromised, right? No diagnostic clues on history or physical examination. We have done a thorough history physical examination and we have done all these obligatory investigations. Despite doing all this, diagnosis is not yet arrived upon, then we call it as pyrexia of unknown origin. Clear? So I want you to by heart this definition, because on this definition MCQs will be asked. Either regarding what should be the temperature or what should be the duration of illness, or which of the following is not part or is part of the obligatory investigations. Clear? Now, there is a similar term which is called as inflammation of unknown origin, or IUO, inflammation of unknown origin, which is nothing but a condition where inflammatory markers like the CRP or ESR is persistently elevated, but patient does not have fever. Rest of the thing is same as the definition of the pyrexia of unknown origin. Instead of fever, we are putting elevated ESR or CRP, inflammatory markers. When do we see elevated inflammatory markers? When we have an inflammation like rheumatoid arthritis, SLE, right? Some bone infection, abscess, trauma, these can be elevated. But once we have the diagnosis, we can explain why ESR was elevated, CRP was elevated. But if you encounter a patient where these parameters are elevated for more than or equal to 3 weeks, and you have done all these obligatory investigations, and yet you do not have the reason why ESR or CRP is elevated, we call it as inflammation of unknown origin. Okay, and essentially the same disorders which can present as pyrexia of unknown origin can present with inflammation of unknown origin, and that is why whatever approach we are going to discuss today applies to both, whether patient presents with fever and no diagnosis at site, or patient presents with raised inflammatory markers and no diagnosis at site, the approach is going to be similar. Okay, but before I talk to you about how do I approach a patient who presented with fever of unknown origin, there are two more things we need to understand. What are common causes which can present with fever of unknown origin, and can someone manipulate the situation to appear like he has got fever of unknown origin, right? So first point is, what are common causes for fever of unknown origin? In the Western population, the most common causes, not a single cause, it's a category. We call it as non-infectious inflammatory disorders. Non-infectious inflammatory disorders. Inflammatory disorders, usually abbreviated as NIIDs. What comes under these NIIDs? We have autoimmune disorders. Examples for autoimmune disorders like your SLE, rheumatoid arthritis, they are the examples for autoimmune disorders. SLE, rheumatoid arthritis, and all whatever you study under rheumatology is an autoimmune disorder. Then you have something called as autoinflammatory disorder. Can anybody give me an example for an autoinflammatory disorder? Autoinflammatory disorder. See, autoimmune disorders are where your immune system is targeting tissues, either by producing antibody mediated immune injury, or the cell mediated immune injury. You have plenty of examples, right? Endocrine autoimmune disorders like the Graves disease, Hashimoto's thyroiditis, right? Addison's disease. Then more systemic autoimmune disorders like SLE, rheumatoid arthritis. What are these autoinflammatory disorders? Autoinflammatory disorders are those disorders where inflammatory cytokines are causing tissue damage without any direct involvement of antibodies or cell mediated immunity. A classical example for this, many of you may be familiar. The example is familial Mediterranean fever. Familial Mediterranean fever. It's a very classical example and a repeatedly asked MCQ topic itself. Okay. Then third is granulomatous disorders. Granulomatous disorders. Can anybody give me an example for a granulomatous disorder? Very famous granulomatous disorder is sarcoidosis. Sarcoidosis, right? So these collectively we call them as non-infectious inflammatory disorders. They are the most common cause for someone presenting with fever where diagnosis becomes difficult, literally getting classified as fever of unknown origin in the Western world. But when it comes to non-Western population, means India. So in country like India, it is the infections. The most common cause for fever of unknown origin is infections. And when it comes to infections, I want you to remember two important infections here. Among them, the most common cause is tuberculosis. And particularly you have to remember it is the extrapulmonary. The pulmonary tuberculosis is generally easy to diagnose. It becomes evident by itself because patient is going to cough. Even if he is not coughing, on the chest x-ray you will see the changes. Extrapulmonary TB, tubercular osteomyelitis, or tuberculosis of the lymph nodes, tuberculosis of the spleen, right? That is where you will have difficulty to diagnose. The patient will present with fever and you search and finally you reach the diagnosis, right? Then other than that, what other infections you have to remember is infective endocarditis and chronic malaria. These are important causes apart from cancers and other disorders. These are important causes in the non-Western world, including India. And please remember, Indian studies and also some other Asian studies have showed that more than 50% of the patients who present with pyrexia of unknown origin in India, more than 50% of cases are indeed because of tuberculosis. That is why when you go to most of the doctors, they try to do some basic initial investigations. You have no clue at the diagnosis. They just start the empirical treatment with ATT, anti-tubercular therapy, and many patients respond well to that, right? Okay, so these are common causes. But one more scenario that is quite common is someone trying to manipulate the doctor to think that he has encountered a situation where he is not getting the diagnosis for the fever. So there are two terms for us to learn here. One is factitious fever and fraudulent fever. Okay, the difference between the two are often asked as MCQs. They will give you a scenario like this is what patient is doing and what is the diagnosis. Is it factitious fever, fraudulent fever, or fever of unknown origin? Okay, what is factitious fever? Here patient induces fever. For example, by injecting contaminated water. Patient himself takes an injection of a contaminated water, he will develop fever. He'll come to you. You may not get any other history points or physical examination findings to reach the diagnosis, right? Then you will do all basic investigations. You are clueless. You would say that anyway fever is settled, so let us see how things progress. He will again go home after a few days. He will again inject contaminated water. He will develop another spike of fever. He will come to you. No diagnostic clues. You will be left with no possibility of an easy diagnosis. This situation is what we call as factitious fever. When he comes to you, you put a thermometer and check, you get that he has fever. That is where you will be really confused, because when I'm checking, he genuinely has fever, but I'm not getting any cause. We call this situation as factitious fever. But there is also one more thing called as fraudulent fever. What happens in fraudulent fever? Patient manipulates thermometer. Means in the factitious fever, patient is inducing fever. Fever to hai. When you check directly, you know that he has got fever. But in fraudulent fever, he says I have got fever, and when you hand over a thermometer for temperature checking, he will manipulate the thermometer, right? Either quickly dipping into a hot glass of water, or sometimes, in fact, in my experience, I've seen a patient bringing in a hot kettle in his sling bag, putting it in that, and then she used to hand over the thermometer, and every time I was getting 100.5, 100.6, multiple occasions, because she wanted leave from the school. Happens. Such scenario, when patient manipulates the thermometer to give you a falsely elevated reading, we call it as fraudulent fever. When patient induces fever in themselves, we call it as factitious fever. These two things should be ruled out before you come to a conclusion that you have reached the stage of calling a patient as having pyrexia of unknown origin. Clear? Now comes the real question. Once I've landed in a situation where I have a patient with fever, genuine pyrexia of unknown origin, right? I have done a thorough physical examination, a good history, and I've done all the obligatory investigations and have not reached the diagnosis. How do I approach further? So Harrison gives you a algorithm for that approach. Okay, so I will take you through the approach. As long as you can remember and recreate this approach in your final prof exam, you will definitely get close to full marks on your written paper. Okay, so what the approach says, approach starts with the basic definition of pyrexia of unknown origin, which is fever of 101 Fahrenheit or higher, illness duration of more than or equal to 3 weeks, and not a immunocompromised state. That is the basic definition. We have done a thorough history and physical examination. We have stopped antibiotic and steroids. Please remember, steroids can interfere with the inflammation and thus can mask the fever. So we have done that, and we have done the obligatory investigations, which I have given you the list, right? So here Harrison, he just goes on elaborating them separately. It is more easy for us to remember it as complete blood count, LFT, RFT, instead of breaking it down. So all the required investigations are done. We have ruled out the manipulation of the thermometer or fraudulent fever. Okay. Then after that, there's one more important scenario that we have to remember is drugs. Drugs can cause fever. Plenty of drugs can cause fever. We call it as drug fever. How common it is? Extremely common. In fact, in my own pyrexia of unknown origin clinic, every third patient who was labeled as having pyrexia of unknown origin, final conclusion was they had drug fever. We stopped the drugs and the fever resolved. Right? In fact, I had a patient who was started on azithromycin weekly pulse azithromycin for acne, and she had developed pyrexia of unknown origin. Some other physician had done an extensive investigation. Everything was done as per the protocol and no diagnosis at site. So when they came to us, we just went through the drug history. Then we decided that we will stop all her medications. We stopped her azithromycin and the isotretinoin that she was started on, and the fever settled. So now we had a clear diagnosis that this was drug fever. They would rather ask you MCQs about what are the common drugs known to cause fever. Okay, so Harrison mentions a small list of common drugs which are known to cause fever, which includes allopurinol, carbamazepine, lamotrigine, phenytoin, sulfasalazine, furosemide, and antibiotics including sulfonamide, minocycline, vancomycin, beta-lactams, and isoniazid. These are common drugs. But please remember, before you step further into investigation of pyrexia of unknown origin, if a drug is not absolutely necessary, it can be stopped, please stop. That is a important point to remember. If a drug can be stopped, please stop. But if there are some drugs which are absolutely necessary, like patient is having let me say an atrial fibrillation and you started on a rate lowering drug, beta blocker, you are not even started an antiarrhythmic, you may not have the flexibility to stop. In that case you can hold, but otherwise if the drug is not absolutely necessary, stop before you further investigate. To summarize again, we started with a patient who presented with fever 101 degrees Fahrenheit or higher, 3 weeks of duration of the illness, not an immunocompromised individual. We have done a good history as well as physical examination. We have done the obligatory investigations. We have ruled out the possibility of manipulation of the thermometer by the patient by directly observing or recording the temperature by ourselves. And we have stopped the drugs and ruled out the drug fever as a possibility. Now we have a genuine case of pyrexia of unknown origin. What should I do next? The most important thing next is to look for PDCs. PDCs. Now you might ask me what this PDC stands for. PDC stands for potential diagnostic clues. Potential diagnostic clues. Many a times by this time you will have some diagnostic clues from your experience or from the history. You may be able to extract something which might lead to the diagnosis. Just to give you an example, we had a patient who had a fever of 4 months duration. Extensive investigations, multiple hospitalizations at different locations, hi-fi hospitals, basic hospitals, government hospitals, everywhere, and no diagnosis at site. So when she came to us, we also did all the obligatory investigations, no diagnostic clue. And then when we were like at this point of time, we labeled it as pyrexia of unknown origin, and we went back to the patient history and whole of the records. What we noticed was in one of the previous x-rays, which was done early in the course of presentation, like first week of presentation with the fever, she was hospitalized in one of the peripheral hospitals. There they had done an x-ray. All I could see was a slight haziness in her right middle lobe. Subsequent x-rays done in other hospitals were also clear and normal. But for me, that was a potential diagnostic clue. Means I can localize, at least problem may be related to respiratory system, may not be related to cardiovascular system, may not be related to other systems, may be related to respiratory system. So we take it as a potential diagnostic clue. So if such a potential diagnostic clue comes to light, in that case, next step is simple. Guided diagnostic test. Means what? You have found a clue, trace the clue instead of trying to do all unnecessary investigation. Just follow that direction. You may hit the diagnosis. So what we did in that case was, we went ahead with a CT scan of the thorax. One X-ray had showed a slight haziness in the right mid lobe, remaining X-rays were all normal. We went ahead with a CT scan of the thorax. And once we did the CT scan of the thorax, we noticed that there was a consolidation in the right mid lobe, small consolidation. Patient had no cough, right, only fever, and there was a consolidation. Now the question is, what is the next step? Because if she had cough, I could have asked the sputum culture. I could have done the other tests for tuberculosis. That was not a possibility. So what we did was, we did a CT guided biopsy of the site from that consolidated region. And biopsy turned out to be tuberculosis. So that was a case of tubercular consolidation. Usually tuberculosis presents as a cavitatory lesion. It is less likely to present as a consolidation. That's why I said most cases of pyrexia of unknown origin are nothing but atypical presentation of common typical infections. So once I had this biopsy report confirming that there were caseating granulomas and the biopsy specimen was staining positive for the acid fast bacilli, done, the diagnosis was established. We started her on ATT and she started doing well. That was a 15-year-old child, and now she is a professional medico. I think she has completed her undergraduation and she is pursuing her post-graduation in dermatology. But they had roamed around different cities and 4 months to reach the diagnosis. So revisiting history and doing a physical examination again and again is very, very important when we deal with a patient with pyrexia of unknown origin, because that will sometimes throw some new light into the direction. जैसे कि CID में होता है ना, दया कुछ तो गड़बड़ है, sometimes that गड़बड़ becomes evident. So if potential diagnostic clues become evident, do a guided investigation, trace in that direction. If potential diagnostic clues are absent, right, you don't have much choice. Potential diagnostic clues, nothing is visible from history, examination, I'm not getting any clue. Or sometimes what happens, we can get misleading potential diagnostic clues. Again, giving you an example from the experience. So we had a patient with pyrexia of unknown origin, all standard workup done, and somewhere during the course of treatment he started complaining of throat pain. And when a localized imaging was done, there were some signs of inflammation on the CT scan. So we thought, okay, there may be a retropharyngeal abscess or something like that, or maybe a tubercular abscess. So we did more detailed evaluation, and then it turned out to be a traumatic inflammation and no infection. That case took another 1 year and another 1 month, and then finally we diagnosed that patient as having the colon cancer as a possible cause for fever of unknown origin. So in such cases, this PDC was misleading. So it wasted 1 week of our time searching in that direction. But as long as you get a potential diagnostic clue, it is better to follow that direction. If potential diagnostic clues are absent, or you return to the baseline with no diagnosis, the PDC was misleading. In that case, what should we do? The next step is to do the serum cryoglobulin levels and the fundoscopy. That can help us to identify some vasculitic disorders. And fundoscopy also, mainly there are retinal vasculitis as well as fundus can show changes with respect to the infectious endocarditis. So those clues you may get when you do cryoglobulin and fundoscopy. In India, this step is not routinely followed because these are not important causes for pyrexia of unknown origin. We just jump to the next step. What is the next step? This is a game changer when it comes to diagnosis of fever. That is fluorodeoxyglucose positron emission tomography or PET scan. Since the PET scan has come, this whole algorithm has become simple. Back in 2009-2010 when I started the practice, and when we opened this every Thursday, we started doing this fever clinic. It was a challenging task for us to take the PO to the diagnosis. We could not diagnose more than 1/3 of the patients of PO, despite all our efforts and investigations. Some of them improved on their own, some of them succumbed also. They died without a diagnosis. But since the PET CT has come into picture, the things have changed. So what we do is, early in the course, instead of trying to beat around the bush, if I am not getting a potential diagnostic clue right now, we go ahead with the FDG PET. Now, if PET is not available, there are other scintigraphic scans like the gallium scan or labeled leukocyte scan, but the preferred investigation is fluorodeoxyglucose PET. Why this is an important investigation? Because what is this agent used here is fluorodeoxyglucose. We are using glucose. And now think about it. If in the body somewhere I have inflammation, let me say that in my lungs there is an inflammation. Let me say right upper lobe there is inflammation, right? So then that tissue will require more glucose or less glucose. Obviously an inflamed tissue will require more glucose because it is metabolically more active. So when we do the scan of all the tissues and the relative amount of glucose that they are taking up, this area will show up as taking more glucose than rest of the body, right? So this fluorodeoxyglucose PET scan can directly take me to the site in the body where there is inflammation present, because that tissue will be taking extra glucose than the surrounding. It shows up very clearly. So what we do is we do this scan, And then if the scan is abnormal, that it is showing that some tissue, some area in the body is showing increased uptake of the fluorodeoxyglucose. That means that is where inflammation is there. So I need to do further investigations there, right? Depending on the site, I can either do the biopsy or I can put a needle and take a sample for culture. And in most cases, you will have the diagnosis. Once the diagnosis is done, we treat accordingly. I just gave you an example, right? A female presented with fever and we had some potential diagnostic clue in the form of a slight haziness on the chest x-ray. If that case had presented today, right, then the fluorodeoxyglucose PET would have shown that that hazy region is showing increased uptake. In that case, again, my route would be I would have put a needle and taken a biopsy sample. I would have cultured the biopsy sample as well as looked at it under the microscope, and either the culture or the microscopy would have given me the diagnosis. But if the fluorodeoxyglucose PET scan also returns normal, right, in that case, what should I do? So this is the most important part. See, 90% of cases today will be diagnosed with the fluorodeoxyglucose PET, but if I'm not getting anything there also, then we have to revisit the history, physical examination. Many a times, some finding which was not evident earlier starts becoming evident now. Again, based on that finding, you can do a guided investigation. We call it as PDC driven invasive testing. If you don't find clue there also, you can do a chest and abdominal CT, temporal artery biopsy, especially if the individual is more than 55-year-old, where patients can often present with temporal arteritis. But these are like shooting in the dark. Now you don't have any clue, you're just trying to do random investigations. You may get the diagnosis, good, treat accordingly. If you don't get the diagnosis, in that case, if the patient is stable, then you can just start them on anti-inflammatory agents. If the patient is deteriorating, you can't keep quiet. You need to do further investigations. So what is the take-home message from this approach? Rule out the fraudulent fever, drug fever, right? And after that, if you have the diagnostic clues evident, follow that direction. If diagnostic clues are not evident, do the fluorodeoxyglucose PET. So if they ask you an MCQ, what is the investigation of choice for a patient with pyrexia of unknown origin? Today the answer is going to be fluorodeoxyglucose PET. PET में अगर किसी एक रीजन में increased tracer uptake दिखता है, तो then do a guided investigation, do the biopsy and culture taken from that site. If you don't get anything in the PET, again revisit the history, revisit the examination, you may get some clue. That is how we approach. Now before I sign off, right, I'll give you an example. So here is an example of a case reported in a journal. I have given you the source also here in the link. You can go through that. So here a 75-year-old presented with, he had an aortic vascular prosthesis because he had an aneurysm. He had an aortic aneurysm. They had put a prosthesis there. Okay. And then he also had a metastatic prostate carcinoma. So two things were already there. He had a cancer because of prostate, and he had an abdominal aortic aneurysm for which they had put a stent or a prosthesis. Now he presented with fever and night sweats. All routine investigations had not given any clue. So they had to label him as a case of pyrexia of unknown origin. And because they did not get any potential diagnostic clue, they went ahead with the fluorodeoxyglucose PET. And when they did the PET, what they noticed was there was an infection of the aortic graft. So when you look at this image, you can see that there is increased tracer uptake in the site where the graft is there. You can see this color PET image. All that fire is the tissue where there is increased uptake of the glucose because there is inflammation. So now they notice that there is a prosthesis which has been infected. So how do they proceed further? They have to either take that prosthesis out because it is infected, give good antibiotic coverage and put a fresh prosthesis, and that is how they handle this case and the problem sorted. Otherwise all other investigations had not given them any clue. So since the advent of the fluorodeoxyglucose PET, the diagnosis of pyrexia of unknown origin has become relatively easy. But nonetheless, most important thing, even more important than that, is good history and physical examination. If you do good history and physical examination, you may not land up in a situation where you start calling the case as pyrexia of unknown origin. I was giving you an example, right? There was a patient who had a haziness in the right mid-lobe that turned out to be tubercular consolidation. That was labeled as pyrexia of unknown origin because this potential diagnostic clue was ignored by the previous treating team. So later on, either me or if not me, somebody else would have picked that up as a potential diagnostic clue. So history and physical examination is something which cannot be overemphasized at any point of time. This is very, very important, and that is why we are doing a lot of emphasis these days on history taking and physical examination. We are running those batches in the app, as well as if you notice the questions, right? Even recently concluded FMG exam, there were plenty of questions which are rooted in the basics, history taking, basic examination, instead of all those hi-fi new drugs. Exam is changing according to the need of the situation. So all of us also will start focusing more on the basics. Once we I'll just to give you an example. One of my friend had labeled the patient as pyrexia of unknown origin, but his professor made the diagnosis within 2 minutes of encountering the patient. He was in a medical college, he was an assistant professor, and his unit chief, he had treated the patient in private clinic. He got him to the medical college because he had no way to make a diagnosis. His professor examined him, and in 2 minutes he said, I have a diagnostic clue, I have a PDC, let's investigate. And final diagnosis for that case was Kikuchi's disease, called as Kikuchi's disease. That's a condition where you have inflammation of lymph nodes. It's a lymphadenitic disorder, autoimmune disorder. Only lymph nodes get affected, and that can cause fever. The diagnosis was missed because my friend only examined the cervical lymph node. He was that too not a proper examination, so he missed the enlarged cervical lymph nodes. Patient had enlarged axillary and multiple enlarged lymph nodes. Just because he had missed those enlarged lymph nodes, investigations were not giving any clue. The professor just felt the lymph nodes. He said, okay, lymph nodes are enlarged, let's do a biopsy. And the biopsy report reported it as Kikuchi's disease. Patient was put on steroids and fever sorted. Right? So I hope we have learned the algorithm, memorize the algorithm, particularly be familiar with the objective definition of pyrexia of unknown origin that we have learned today. Common causes in Western population, non-infectious inflammatory disorders, non-Western population, infections, among them tuberculosis. Among the tuberculosis, it is the extrapulmonary tuberculosis which is more common, and please be aware about the importance of fluorodeoxyglucose PET. That's it for today. Tomorrow we will be starting with the neurology part of the Reed Harrison series. We're starting with how to evaluate a patient who presents with weakness on some part of the body or whole of the body. Whatever the approach we need to take to make a diagnosis from patient presenting with weakness to an objective diagnosis saying that patient has got a lesion in the brain or lesion in the spinal cord or a neuromuscular junction. We can also label it as localization. That is what we are starting today. So I'll see you tomorrow 4 p.m. all of you. Thank you guys. Thank you all. Thank you. Thank you all. See you. Bye. Bye-bye.